welcome our distinguished guests, Professor Hatem Samir, Professor of Neurology, Cairo University, and President of the Egyptian Neurology Society, and Professor Abdullah Katib, Professor of Obstetric and Gynecology, Cairo University also. And they are our dear friends, and I would like to thank them for giving us part of their time. And also we have our distinguished guest speakers. We're gonna have this session about HIFO, high intensity focused ultrasound. And last year we used to say it was a new innovative technique. Now it's not a new innovative technique. It's just an innovative technique, non-invasive treatments of different pathologies that we might help in showing part of its indications currently. Now I would like to welcome my dear friend, Professor Dr. Martijin Boomsma. He's gonna give us, he's a professor of intervention in Isala Hospital. He's gonna give us his experience on MR-guided HIFO in treatment of uterine fibroids.
Thank you, Professor Fassi. It's great to be here again after last year's meeting, and happy to contribute for the fourth time with our research group. The first talk I will give today is about how do we actually assess suitable patients for HIFO treatment in symptomatic uterine fibroids. A quick recap. We use focused ultrasound instead of the diagnostic divergent ultrasound to actually deposit energy in a certain place in the patient, in this case a myoma. And we use MR-guided imaging for targeting, but also for temperature evaluation. And it makes this a really safe procedure. And with the latest equipment, we have hardly no adverse events anymore. So this is a typical case. A patient is presented with a large fibroma. On the top, you can see there's little to more T2 weighted components in the tissue, which is renowned for less accessibility for heating. But nevertheless, the upper row, you can see we have a total vascular occlusion of 100%, and the lower row, we were not able to heat the fibroid. And it's very difficult, actually, to really assess in advance whether a patient is suitable or not, so you get a technical failure. So there are many different parameters you have to address or to assess. You have to look for how much subcutaneous fat is there, what's the position of fibroid, anterior or the posterior side of the uterus, and most prominent is the signal intensity T2 weighted imaging. If there are high components, you go from a Funaki 1 to Funaki 2 or Funaki 3, depending on the signal intensity of the fibroid with regard to the uterus itself. And we always look for contrast enhancement, whether or not it's homogeneous, where there are cystic or necrotic components. So there are a lot of other factors that are important. The number of fibroids, if there are calcification, how is the uterus positioned, is there a concomitant adenomyosis, but also what are the symptoms? Is it a mass effect on the bladder, or is it menstrual problems like menorrhagia, metrorrhagia, etc.? And in many occasions, there's also still a wish to conceive. So fertility here is an issue, and HIFO seems to be at a pole position to treat patients who want to preserve the fertility. So here again, you see the screening. Funaki on the left, Funaki 1. In the middle is Funaki 2. You see some high T2 components, and it resembles the uterus. And Funaki 3, you show the myoma that actually has higher T2 signal intensity with regard to the myometrium. So Funaki 1, let's go. Funaki 2, yeah, let's go. Funaki 3, we don't go there. But we know that this is not always the case. If you actually are very strict in this classification, you will undertreat. You will not give patients that can be treated. So you withhold them a treatment, and if you just enroll all patients for Funaki 3, you know you will end up with a lot of patients that will have a failure. So, screening. Funaki 2-3. So this is something in between. I always call it the 50 shades of radiology, 50 shades of gray. The easy cases are easy, but when it's, a lot of indeterminate cases. So what should we do with this one? Yeah, we said, let's treat it, and we got an MPV, total vascular occlusion, 100%. Next one, also Funaki 3, some Funaki 3 components, we were unable to get heating in the uterus. And this one, and the screening MRI looks less severe than the other one, which we had at 100%. So many parameters, and we heard some talks about artificial intelligence. I always like to call and to talk about human intelligence, because we do the same thing in our brain, right? There are many parameters, and the expert is always combining these things to say whether or not he sees a feasible chance on perceiving success. So, the recent question we had, does increased experience by the physician with hammer-hyphen technique influence the assessment of technical suitability? And does this reassessment affect clinical outcomes such as non-perfused volume ratio or symptom reduction and re-intervention? So we took a retrospective cohort in which we included 102 patients from several cohorts. In the beginning, we included a wide variety of patients for screening, because that's one part of the success of this database, that we were not really restricted in whatsoever in looking and investigating at patients. And we reassessed all these images again with a first assessor in our hospital, an extra assessor in our hospital, and we asked an assessor from Finland, a hospital in Turku, who has a great experience, and they were just were awarded with a Center of Excellence. So we asked, let's just ask another one, not related to us, to also assess these images and define definitive eligibility. So we had a screening MRI that we gave them to look at. We gave them the age of the patient, the symptoms, whether or not they had future childbearing wish, and finally, is this patient eligible, yes or no? And then on the right you see here many reasons for exclusion. Too much subcutaneous fat, too many fibroids, there's no dominant fibroid that can explain the complaints, suspicion of malignancy, dominant adenomyosis, a fibroid larger than 10 centimeters, too much or too heterogeneous T2 signal intensity, an intercavitary or pedunculated fibroid, diameter of the myoma less than 2 centimeters, dorsal side of the uterus to the abdominal wall more than 12 centimeter, calcifications, no or too heterogeneous contrast enhancement, so on, so on. So this is not easy. So we looked at agreement, we looked at description of reasons of exclusion, and we did a lot of statistical tests, of course, to look at non-perfused volume, quality of life, and finally, re-intervention rate, because that's something that the insurance companies are very interested in. So, as you can see here, that the external validator was more strict than we were. Evaluator 1, 57%, evaluation 2, 67%, and the external evaluator 51%. So if you look at all these other combinations, we see that the total cohort versus the final eligible cohort didn't give any clues to any parameter whether or not you should, that could explain the difference in volume reduction. But all the parameters taken into account, you see here that there was more volume reduction in the final eligible cohort than in the original cohort which we assessed. And also a little bit increase of non-perfused volume, but it was all non-significant. So if you talk to a statistician, non-significance is is non-significant, right? So, but I try to prefer to think in trends as well, because I think the world is not really binary. So you can also see the volume of treated fibroids in eligible cohort was less, and we definitely treated less Funaki-free patients in an eligible cohort. So I won't go over all these different parameters, but in the end you can see if you have a more strict assessment of all these different parameters, you see that signal intensity is a very important one. It goes down from 9 to 5, and an external evaluator actually excluded 34. So he was really relying on the heterogeneous high signal to intensity. And concomitant adenomyosis. Everybody who looks and reads screening MRs knows that it can sometimes be difficult. Okay, it's a myoma, there's a lot of high T2, but is it actually maybe an adenomyoma instead of a fibroid? So sometimes discussion, sometimes it's concomitant presence. And big myomas, well, after a certain amount of volume, it is very difficult to treat them in, let's say, half a day. So, final results, a combination of factors for exclusion were reported in 63 cases. High variation, most reported too large fibroid, too many fibroids, dominant adenomyosis, or this fibroid is actually not responsible for the complaints of the patient. Small agreement between reasons of exclusion only in 9 cases, partial agreement 23, no agreement whatsoever. And if you look at the quality of life, there's no significant difference between the original screening cohort and the final eligible cohort in symptom score reduction. If you look at survival rate with regard to reintervention, I think that's always important because insurance companies say, okay, HIFU is great, it's non-invasive, women want it for several reasons, but if we then have to do a second procedure in several years or maybe the next year, this is not what we want because they have to pay twice for the same patient. But we see here that, there are actually less hysterectomies as a reintervention, same amount of myomectomies in absolute numbers, but relatively more, and uterine embolization, no differences. So all these other, sometimes we do a re-HIFU, you can do that. But we also took those patients as a reintervention. But if I wouldn't be in love with HIFU, I would say these are devastating results, right? So you get a lot of reintervention within 2 years. And this is something actually we need to tackle. So in conclusion, yes, more clinical experience results in stricter screening, but there's only moderate agreement in assessment of suitability. We have to be honest, stricter screening doesn't show a statistically significant improvement in clinical outcomes, but reinterventions did decrease from 46% to 37% with a trend of a P of a 0.28. So having said that, what's next? What should we do? Does anybody know? I don't know.
More cases. More cases.
Yes, I think that's the right answer. We need to treat more patients in more centralized centers. So, of course, we have the usual suspects. There was incomplete follow-up. The first 25 patients we treated in Isala, we have to be honest about that. Those were learning curves. You need 25 patients to actually learn how to treat these patients. And I think we need to dive deeper in multiparametric MR imaging to go for deep learning screening models. Because if you take a look at deep learning, there are more than a few sequences or more than a few parameters that you can look at about eligibility or based on imaging alone. I'm happy to take any questions or suggestions. Thank you very much.
Thank you, Martijin, so much for the presentation. We're going to postpone the questions till the end of the session for